So this is a urine specimen. So this is a cytospin preparation. As you can see, the cell were concentration at the periphery of this circle. And there was a spot that you can see. The cell here looks more hyperchromatic. So we have some other cells in adjacent to compare. So this is an intermediate cell of the urothelium. This is also the urothelium intermediate cell. So these are benign urothelium cells, and these looks more hyperchromatic. In addition, there were increase of nuclear and cytoplasmic ratio, so increased NC ratio. The nuclear contour seems to be a little bit irregular. Because there's only these spots, our Cytotech do a repeat cytospin preparation. This looks much better, much easier for interpretation. But in the specimen, you can see majority of the cells are actually benign urothelium. However, if you screen, there was some cells looks increased NC ratio. This is pretty much what we do in the pap smear, that we will screen to search for any cells with increased NC ratio with hyperchromasia. So these cells looks typical. But the nuclear, it's not markedly enlarged. Basically, the size is similar in compared to the adjacent cells. Here we also see some cells with increased NC ratio. And I think that's it. That's increased NC ratio. The hyperchromasia in this preparation is not very prominent. The coarse chromatin is not very prominent. So I guess the previous like a preparation, it could be true, but it could also be artifact from the cytospin. So in this specimen, I think it is reasonable that we call it suspicious. The patient indeed has a past history of high-grade urothelial carcinoma, but it's in the renal pelvis. It's upper tract. It's not in the bladder. So sometimes in the upper tract lesion, the shedding cells could be scanned, so which can look like this with like more normal cells, but scanned atypical cells. So indeed, I think in this preparation, the criteria does not fit for a definite diagnosis of high-grade urothelial carcinoma. So we call this specimen atypical. But the tip is to screen for these high NC ratio cells and with hyperchromasia, and it can be hiding between the normal urothelium cell. The next specimen is much lower with much lower cellularity. However, if you check, most of the cell has atypia. This is very different from the previous specimen that the majority of the cell are normal. But here you see most of the cell has atypia, has hyperchromasia. And even though we have a significant drying artifact, you can still appreciate that the nuclear shape is not rounded. It's like angulated. The chromatin pattern seems to be coarse, and it is hyperchromatic. So in this specimen, I think it is okay that we just call it positive for high-grade urothelial carcinoma. There is only scant benign cell in adjacent, but majority, like more than 90% of the cell, looks very atypical. Even though they have marked degeneration, it is still a good sign, suggests that it is positive for urothelial carcinoma. The patient indeed has history of urothelial carcinoma, so it is persistent of the disease in this patient. So next, let's move to some body fluids. The first specimen is from an ascites. The patient had the past history of pancreas cancer. So in this specimen, we see most of the cells are like a loosely cohesive or as single cells, and there are prominent signaling ring cell feature from here to there. So occasionally, for primary pancreatic cancer, it can also have sigmoid cell morphology. So in this specimen, we know it is positive for adenocarcinoma, and the lesional cell, the tumor cell, compose most of the cell that we see here. And we can definitely appreciate marked nuclear atypia with vesicular chromatin, very prominent nucleoli, and most of the cell have this eccentric pattern. So it is adenocarcinoma, and because of the past history is not gastric, it is pancreatic cancer. So I think it is still okay that it is compatible with pancreatic adenocarcinoma, but it is not very common to see this morphology in pancreas cancer. The next specimen is a pleura effusion specimen. The patient had a past history of primary lung adenocarcinoma. In this specimen, there are some proteinaceous material inside the body fluid, the effusion. So for the cytospin smear, we see a lot of cell like cohesive with some sort of like a material in the background. So we need to go to high power to check if there's any diagnostic cell. So here we definitely see very atypical cell. So here there's a very large nucleus with very prominent nucleoli, almost as big as the lymphocyte. And the cytoplasm is like bubbly, it's foamy, so it is compatible with adenocarcinoma. And it is hiding inside this like a proteinaceous material. And the cellularity is not very high, but from here to there you can definitely see some cluster of cells, suggest that it is glandular differentiation with glandular arrangement. So this is positive, compatible with recurrence of the primary lung adenocarcinoma. And if you check the cell block preparation again, the lesional cell is scant. So here you see majority of these cells should be histiocytes. But from here to there, you can see definitely a cluster of glandular cell with marked atypia, and this is adenocarcinoma. So the cell is not so many, but still diagnostic. So next we have a new patient who is a 61-year-old female. And this is a new pleura effusion. So this is the most typical pleura effusion specimen that we will see for primary lung adenocarcinoma. That in the low power, you can already appreciate this three-dimensional cellular cluster. It's a glandular arrangement. So, and it is like a three-dimensional, so it's sometimes difficult to appreciate the nuclear detail, but it is positive for adenocarcinoma. And because this is her very first specimen, we will do a TTF1 in the cell block preparation. And the cell block itself is also very typical for primary adenocarcinoma. We see a lot of these glandular structure, and they were prominent like hobnailing at the edge of the cellular cluster. So this is positive for adenocarcinoma. If it's positive for TTF1, the clinician will proceed order the EGFR testing on this very pleura effusion specimen. So we have plenty cells for the examination. Again, this is a recurrence tumor. Yeah, adenocarcinoma of primary lung. So again, you can see it's more like a proteinaceous stuff in the background. But there are still positive cells like admixed with this proteinaceous material, and this is also high-grade adenocarcinoma. So this is positive for recurrence. So lung is the most common organ for distal metastasis, and this is again a different pleura effusion specimen. The patient does has a prior history of gynecology cancer, which is a endometrial cancer, and she has received multiple surgery and has multiple metastases. And in this specimen, definitely we can tell that it is adenocarcinoma. We have a lot of three-dimensional glandular cluster, and the nuclear atypia is very prominent, and variation of size, like a very atypical nucleolus, and these are positive for adeno. And given the patient's past history, it is compatible with the endometrial cancer with metastasis above the diaphragm. So let's move to fine needle aspiration. The first one is from parotid gland. So this is a very cellular specimen. So we like to see this type of specimen because we have a lot of diagnostic material. So we have some cellular cluster. Majority of the cell have these like ovoid feature, a little bit spindle, a little bit ovoid. The nucleus is small and it's regular, so it looks like benign. And it had these myoepithelial morphology because of these oval, like a kidney-shaped cells. So if we are thinking of polymorphic adenoma, we will go ahead to check if there is any chondromyxoid matrix material. So here we find out that there are some like grayish looking stuff in the background. So in the Papa Nicolau stand, the extracellular material will look like this, and you always have these fibrillary edges that you cannot draw a line at the edge because it's very fibrillary. So this is very typical for the extracellular matrix of polymorphic adenoma. So in this higher cellularity specimen, we will still looking for if there is any cellular atypia because it is not so common to see carcinoma arising from polymorphic adenoma. So we need to exclude the possibility of a CAXPA. So here we didn't see any atypical cell. So it looks pretty good for benign polymorphic adenoma. So for benign polymorphic adenoma, we would usually like to see the direct smear for loose stent or for diff quick stent. In this direct smear, the cellularity is very low. We only have a few clusters, but we can definitely appreciate that these uniform mononuclear cells and with association with this fibrillary extracellular material. It is very important that you can see in the specimen the extracellular material has a very close relationship with these myoepithelial cells. This is diagnostic for polymorphic adenoma, because these matrices were produced by these myoepithelial cells. So you want to see that they are intermingled within this matrix material, and it's fibrillary in the like a character. So it is very fibrillary, and it is intermingled with myoepithelial cell. So this would be the diagnostic feature for the polymorphic adenoma. So the next specimen is also from a parotid gland. Again, this is a hypercellular specimen. We see a lot of cellular fragment. And all these cellular fragments have these oncocytic features. So you can appreciate it is still very uniform, but with a lot of cytoplasm. The cytoplasm is dense and granular, and with these like a cyanophilic color at the periphery of the cluster, but oftentimes in the center it will have a little bit orange color inside. So this is oncocyte. So this is benign oncocyte with perfect monolayer sheet with great honeycombing arrangement. And in the background, we can also appreciate there are some cystic degeneration debris. So this is typical for a Watson tumor. Sometimes you will have some calcification like crystal material, which is also okay. So in this specimen, here you also see there are some lymphoid stroma, lymphocytic stroma, mixed with the granular debris. So you see the benign oncocytic epithelial cell with flattened sheet, with large sheet and honeycombing arrangement, and you see this lymphocytic stroma and necrotic cystic debris material. This is diagnostic for Watson tumor. So this is a benign Watson tumor, and these two tumor type is the most common tumor that we will encounter in salivary gland aspiration. So the next specimen is also from the parotid gland. In this specimen, you have prominent cystic background, with most of the cells are these histiocyte with some pigmentation inside. It could be hemosiderin, but it is not so coarse. So I'm not so sure if this is hemosiderin or not. But these are definitely cystic component with histiocytes. So in this type of specimen, usually we want to check if there is any epithelial element for the diagnosis. So without any epithelial element in this type of specimen, cystic fluid only, we will usually diagnose as non-diagnostic, category 1. But if the cystic component have some mucin, and then we will diagnose it as AUS, category 3. So this one, we didn't see any mucin, so we just need to screen for the entire specimen to see if there is any epithelial component. So there is only one tiny cluster of spindle cells, and it has a little bit of like a squamous feature. So these could be squamous epithelium. So this is not very common, but in this scenario, it could be, for example, like just lymphoepithelial cyst, inclusion cyst, simple cyst, or it could be a metaplastic, a tumor with cystic change and the squamous metaplasia. So in this situation, with cystic background and some atypical cell or indeterminate cell, it is also okay that we call it AUS. But because we have residual specimen and the cytotech do mark that we do have some residual, looks like a solid tissue fragment inside. So in this situation, we will usually do a cell block preparation from the residual specimen. So we will do a cell block, and then we will decide if we have some more element for the diagnosis, or we will just call it AUS. Okay, back to the pleura effusion. Here we have a gastric cancer case. This is pleura effusion. So here we see high-grade cells, mostly single cells, some with eccentric nucleus. So this is typical for the poorly differentiated gastric cancer. We also have a new case. This is primary pleura effusion. The patient is a new patient. This is his first specimen in our hospital. And you can see also poorly differentiated adenocarcinoma feature, vesicular chromatin prominent nucleoli, and bubbly cytoplasm with a cluster in the glandular like structure. So we will do TTF1 on the cyto block on the cell block specimen. So this is the cell block. Again, the proportion, the percentage of tumor cell is very scant. So we can demonstrate the TTF1 expression by immunohistochemistry, but if we want to do an EGFR molecular testing, this might be, the tumor percentage might be too low, because you see majority of the cells in the background are lymphocyte, and the tumor cell, the percentage seems to be lower than 5%, so this is not optimal for molecular testing, and we need to address that in our report. So finally, there's pap smear. So the patient is a 39-year-old female. This is her first pap smear in our hospital. So we can appreciate that, okay, we do have a lot of superficial cells, some intermediate cells, so the patient seems to be young. And the specimen, I would have to say, is not very easy for interpretation. I think, first of all, the fixation is not very good, so we have quite some drying artifact. We have a couple cellular cluster with very prominent hyperchromasia. And it is not easy to see the single cell in the cluster. So these we would call it hyperchromatic crowded group, right? So for the hyperchromatic crowded group, the differential diagnosis is with a very wide range. It can be glandular lesion, it can be squamous lesion, it can be reactive, it can be neoplastic. So we have a broad differential diagnosis. But in this case, I would say the hyperchromasia is very prominent. And if you can appreciate the cellular feature, at the edges, there are some spindle cells. So it's likely it's more with squamous differentiation. So this seems to be a typical squamous cluster with really high NC ratio and hyperchromasia. So our main differential diagnosis would be high CO. So originally the screener called this specimen squamous cell carcinoma. I think this is a bit over because we didn't see any necrotic debris, tumor diastasis in the background. So we only see these very tight cluster of squamous cell with hyperchromasia and high NC ratio. There are some, you can see, so this is pretty good for a high CO if you can find these cells. So this single cell has very high NC ratio, coarse chromatin, hyperchromasia, and this is good for the high CO. So I think we have high CO here. So for the high CO cases, we will go ahead to see if we will find any tumor diastasis. But in this specimen, it's very difficult. There are some degenerative cells in the background, but no definite unequivocal tumor diastasis. So I think it is okay that we call the specimen high CO. And in the patient with like a big intraepithelial lesion like this, because we saw along the smear direction, we see a lot of cluster of cell looks like high CO. So in the patient with a large lesion of high CO, it is not uncommon in the excision biopsy specimen, you will see microinvasion. So for the microinvasive SCC, usually you won't see very prominent tumor diastasis for the diagnosis. So I think there is a chance for microinvasive SCC in this case, but because of this pap smear and we didn't see any tumor diastasis, like a very good tumor diastasis that we would be confident enough to call it SCC, we will call this specimen high CO. And the patient still will get the appropriate follow-up management by these diagnoses. So we call this high CO, and we need to look for the past pap smear, but because this is the first pap smear the patient had in our hospital, so it is okay. So this is a high CO case, and we will see the follow-up biopsy. Okay, so this is for today.